Welcome all. We're so glad you could join us today for this webinar on suicide prevention and intervention in our emergency departments. I'm Tani Hemela. I'm the director of the Minnesota Health Collaborative at ICSE, and I'm so honored to be here today as host and moderator for this webinar with our presenters, Jessica Malone of Hennepin Healthcare and Suzanne Witterholt of Allina Health. I'm honored and honestly tickled pink. I've had the chance to work with both of them through this effort over the past few years and with many others across Minnesota. So I think today you're going to be able to gain really a lot of good information about what healthcare systems are working on and doing for this important topic right now in Minnesota. So our objectives for today, mostly, we want to help you move from knowing what to do to actually doing it. We have a lot of knowledge to share, but really getting that impetus to make one change and to help move forward is our aim in all of our work. And a note that everything we're referring to can be found on the ICSE website here under the Mental Health tab, under the Shared Standards and Emergency Departments for people's mental health needs. So just a very brief overview before we get into the meat of it. This effort started out in 2018 when mental health leaders and emergency department leaders across the state came together with ICSE to work on this important issue. And why did we decide to address mental health in the emergency departments? First of all, the rate at which people are accessing the ED for mental health and substance use needs has increased greatly from 41% from 2006 to 2014 nationally. It's even a bit higher in Minnesota. And this compares to only a 14.8% increase for overall ED visits. Additionally, we now know that during the pandemic, EDs in the US have seen even more visits for mental health, suicide attempts, overdose, and violence than before. And as we first convened leaders from across the community on this work and reviewed the evidence and created recommendations, we then also iterated it. So as organizations made changes in real time, we came back and we said, okay, what needs to be changed? And I want to give a shout out to this effort over time where organizations also gathered together in partnership with ICSE and MDH in the Zero Suicide effort over the last year. That just completed this month. And this progress over time and people being able to learn in community with one another really advances the rate at which people can advance evidence-based practices. And that's been really a key to success in our community. So the areas of focus we've had, in addition to suicide prevention intervention, is prevention and management of agitation, as well as medical clearance evaluation. And so a bit about the statistics about suicide. In Minnesota, the suicide rate increased by 90% since 1999, which is huge. And in 2020, the preliminary data show that the deaths by suicide in Minnesota dropped. However, that's the 6th straight year in which more than 700 Minnesotans died by suicide. Also in Minnesota, disparity is a real issue. In Minnesota, suicide death rates are highest among Native Americans, whereas nationally it's highest among whites. And what about ED? Why are we choosing to address this in the ED? First of all, approximately 8% of all adults visiting the ED report suicidal ideation, even those with a non-psychiatric reason for the visit. 40% of people who died by suicide were seen in an ED within 12 months of their death. And approximately 70% of those people at risk do not have an outpatient visit scheduled. And these organizations are working to change that. This is an incredible need and very important to address. And so as we get into the suicide prevention and intervention recommendations, know that these have been updated with the latest evidence. We have new additions since 2019. And pivotally, as part of that, we've incorporated input from patients and family. We asked them for feedback on the work so far prior to the pandemic. One of the comments that really hit my heart and stuck out to me in that time as we conducted those interviews was somebody asked, where are the people in this? We get so medicalized, we have our jargon, we think in terms of workflow. We need to be thinking in terms of people. And getting this input from patients and family really helped with that. So with that, I'm going to turn it over to Suzanne Witterholt. And Suzanne, please go ahead and introduce yourself.
Hi, good morning, everybody. I'm Suzanne Witterholt. I'm a psychiatrist, and I am the medical director for emergency services at Allina Health for the Mental Health and Addiction Service Line. Allina does have 13 emergency departments, and we see about 20,000 people a year in a mental health and addiction crises. So I am very happy to be here. The first thing we're going to talk about here is engagement. And the reason we're starting with that is you can screen, you can do assessment checklists, but if you don't engage with the person who is experiencing a crisis in which they're trying to solve their problem by suicide, you don't have someone who is working with you. So engagement is really about functioning to build the therapeutic relationship, to have a collaborative relationship, and to be able to actually do shared decision making. Also, one of the main things that's crucial about engagement is you're actually starting the treatment for suicidal ideation and suicide attempts when you engage, because you are connecting with the person, and connection with a person, connecting with people, is one of the main preventive measures for suicide. So we can go ahead to the next slide. So the good thing, I'm a behaviorist, and the good thing is, as a behaviorist, everyone throws around the word engagement. I'm like, what does that mean? What does that mean? Well, there actually are behavioral descriptors for what myself as a clinician does to, quote, engage with the patient. And they're really all within the rubric in behavioral studies of what we call acceptance and validation. And there's really three categories: is to validate the person, to generate hope, and to actually do something useful. So if you go ahead to the next slide, I'll just do a brief about validation. What we mean by validation is not that you approve of something or that you agree with someone, but that you not only have an ability to put yourself in what it would be like to be them in this context at this moment. You know, again, one of the things, the principles of suicide intervention, is to remember that suicide is a solution for the person who's thinking of killing themselves. And so I'm trying to put myself in their shoes in terms of what is it that is driving them to have this as the only the only option. So with validation, the bookends of it are really paying attention to the person in a way that you're so mindfully with the person in that moment that from their point of view, there's nobody else in the world but you and them. And you are right there, really trying to listen, not in order to respond, but to really understand them. So that's the pay attention bookend. The other bookend is being genuine. This is not a time when someone's in a suicidal crisis to have what I would call therapy voice. Pardon me if I don't mean to offend anyone, but it really is you're talking to this person like you're talking to your best friend, your partner. You know, this is life and death for this person. So those are the bookends, what we call validation level 1 and validation level 2. And then the rest of them are really going through a process in which being able to finally get to the point where you can tell the person that if I was in your situation, I would feel this way too. And that's where it really hits home for someone. So you can go to the next slide. So this other issue is there's a lot of research on what it means to be hopeful and how to generate hope in other beings. Snyder is the one who has done a lot of that research. But this idea that when someone is so hopeless and in despair, that problem solving has congealed into this narrow, well, I could kill myself, you need to generate hope in that there is a way out of this, that this can be done, and that they're not alone, that you are going to walk with them. So that's really crucial, even if the walking with them is only for a short period of time in the ED in order to connect them beyond that. The other thing is that sums all this up is that actions speak louder than words. When someone comes in a crisis, it's not necessarily the time to say, well, what do you think you could do? It's like, do you need a sandwich? Have you had anything to eat? Can I get you a blanket? How about some cold water? If you're super anxious, can I get you some medication right now? Let's just start with making sure that right now in this moment, I can offer you something that in this moment will help you feel better, as opposed to just sort of launching into a bunch of assessment questions. In behavioral research, this is called implicit functional validation. In other words, you assume the person needs something, you read their mind and you bring it to them, or you ask and you bring them things. So those are really the three things about engagement. Is engaging another person includes this idea of understanding how to validate, being able to give them hope and generate hope, and then actually do something useful.
Thank you, Suzanne. Now, I want to mention also to everyone listening in here today, please feel free to send your questions and comments through the Q&A, and we'll forward those to the presenters as we go. Go ahead, Jessica.
Hi, everybody. My name is Jessica Malone. I'm a registered nurse, and I am the Clinical Care Improvement Manager for Psychiatry Services at Hennepin Healthcare. Over the past couple of years, I have been leading our suicide prevention efforts throughout our healthcare system. So really happy to be here today with Suzanne and Tani to present on this really important subject. We're going to continue with some of the other new elements of the recommendations here, which is, really looking for those concerning presentations that might indicate that somebody has either made a suicide attempt or is at risk for serious self-injury, potentially leading to death. And that recommendation entails that maybe we don't need to screen those patients that we know really might be at risk for suicide, and they really can enter into that assessment and management pathway without that screening. Working on our workflows here at Hennepin, I know that piece is a little bit hard to operationalize, but I would also encourage people to think about this in context of a negative screen. If you see any of these other elements after you screen the patient, and we'll talk a little bit more about that. But examples shown here, single car motor vehicle crash is generally a really concerning presentation for suicide, as well as ligature injuries, reports from friends and family about preparatory behaviors, et cetera. And so we would really encourage people to get a patient who presents with one of these types of injuries into that assessment and management workflow. Next slide, please, Tani, or Patty. Next, we're going to talk about choosing your population to screen. You really have two options here. You can either target your screening to specific people who you think might be at a higher risk level, or you can screen everybody that walks through your front doors. Here at Hennepin, we are Joint Commission accredited. I'm sure many of you are as well. Joint Commission and National Patient Safety Goal 15 does require that all patients 12 or older being evaluated specifically or treated for a behavioral health condition must be screened. At Hennepin, we've taken the approach of universal screening, and I believe OIDA has as well as many other health systems across the metro area and the state. And this is really in line with the recommendations from Zero Suicide, as well as I think the right thing to do, especially working in a safety net hospital setting where we know that people have many comorbidities, both social and medical. We really felt that was the right way to go. It also takes that kind of element of assessing, well, do I need to screen this patient or not, out of the equation. So in fact, it is easier for clinicians, I would say, to just go with screening everybody. And of course, it's better for patient care. Tani mentioned that 8% of all ED comers are at risk for suicide. And if we don't ask people about their risk, we might not understand their level of risk. Next slide, please. And again, related to screening, the recommendation is that a validated tool be used to screen and risk stratify. for the people that you are screening. You want to use a validated tool, of course, and that's also a Joint Commission requirement. The Columbia Suicide Severity Rating Scale, or CSSRS, has been widely adopted across the metro area, and I believe the state as well. It really is flexible in that there are different versions available for different settings and different time periods. For example, there is a since last contact screener. If you're seeing somebody in a clinic setting, you already know their kind of baseline level of risk, and that since last contact version kind of gives an updated view of their risk. And there's also a frequent screener that can be used in the inpatient setting to kind of keep tabs on that risk over time. And you know, all of us aligning around the CSSRS kind of gives us that common language to really understand what a patient's level of risk is and what that means, what the implications are. So I think it's really wonderful that our area health systems have aligned around the CSSRS. It also really provides nice guidance with regard to risk stratification and helps your clinicians or yourself understand what needs to happen next for that patient. Of course, there are other validated tools out there, such as the ED-SAFE, the PSS, the ASQ. I don't find that they're as generalizable across settings and time periods, but there are others that you can consider as well. Next slide, please. Again, back to that idea of looking for those concerning presentations. And here in our little snippet of the workflow from the recommendations document, we see that, you know, if we see somebody who has a negative screen, but your clinical judgment says, you know, there's something with this patient that indicates that they might be at risk, you really want to enter into that assessment and management workflow. You know, patients have told us, I'm not sure if I would tell the truth if I, you know, were encountering a stranger in the emergency department who's asking me these questions. And really, those screening tools are only as good as the answers that the patient provides to you. And there could be many reasons why somebody wouldn't be upfront about their suicidal ideation or if they have plan or intent. Next slide, please. So after screening, and we'll get to the assessment piece in a bit, but patients at some risk for suicide that you're going to be keeping in your emergency department, you want to keep them safe, and obviously that is the case. If you have a secure ligature-resistant area within your emergency department, it's always probably a good bet that you'd want these patients to be roomed there. Back to Joint Commission requirements, Joint Commission does require that patients screened or assessed to be at high risk for suicide must be on one-to-one monitoring in the hospital setting, unless they are in a secure ligature-resistant area and your policy states that they can be in that area without monitoring. Otherwise, you'll want to implement a checklist to make sure that your room that you're rooming the patient in doesn't contain any items that the person could use for self-harm. And you'd want to base that checklist on your environmental assessment and the risks that are present in that space. You know, and this is often a challenge in emergency departments with staffing and kind of the amount of patients coming and going from the emergency department. You know, you want to really consider using the least restrictive interventions, and that's really tough for a lot of health systems. But creativity is needed here to make sure that we're providing empathetic and person-centered care and not, you know, putting undue stress on patients who are presenting to us with suicidal ideation. A couple of plugs for other ICSI publications that Tani mentioned at the beginning of the presentation that are really relevant to our workflow here. You know, your person that presents to the emergency department with suicidal ideation might have the potential to escalate behavior-wise. And so you want to be ready to manage that person's agitation, and again, do so in a respectful and caring manner. There are a lot of tools out there that can be used for agitation management. Shout out to our friends from Health Partners. We're working on implementing the MyATAPS assessment and interventions in our emergency department as we speak, and have successfully implemented that in other areas. MyATAPS is great because it also directs interventions, and those interventions can really be olive branches that we could use to connect with people and make sure that we're engaging, as Suzanne discussed. Things like the warm blanket, a cold drink, aromatherapy can really help people to manage agitation, but also make them feel cared for. And then, of course, before you dispose the patient, you're going to want to conduct a medical evaluation, whether they're headed to an inpatient psychiatric unit, or headed home with a safety plan, or headed to something in between, like residential treatment. And ICSI has wonderful guidance for that as well, thanks to the work of the collaborative. And then on to assessment. You're going to, of course, for patients that you deem to be at some risk, either based on screening or those concerning presentations, to really do that assessment and get that full picture of the patient's risk and protective factors, their level of ideation and intent. Joint Commission, they do require an evidence-based assessment process. So it's a little bit looser than that validated screening tool that you largely kind of use verbatim. They do give you some latitude to be able to use your clinical judgment in formulating that level of risk. We've had a lot of success at Hennepin implementing the safety process, and which I find to be a really nice clinical framework that allows for that clinical decision making. And I'm going to hand it back to Suzanne to talk more about assessment.
Thank you, Jessica. I appreciate this. So I think if you have the next slide up, would be okay. Yeah, so again, let's back up from sort of the principles of assessment and screening. So Jessica's talked a lot about the Columbia Severity Suicide Rating Scale, which is really a short, quick screen that can be done to just see if there's even thoughts of suicide or wishing you were dead when you woke up in the morning, woke up and didn't wake up the next day, but the screen is only as good as the patient being willing to answer the questions honestly. So then you move into the other piece of assessing, which is you're really looking at, as Jessica called them, the concerning presentations. That's also called the indirect indices of risk for suicide. The screenings only ask direct indices. They ask you if you have thoughts of suicide, if you're planning to commit suicide, if you've tried to prepare for that. But it's all these indirect indices that need to be assessed. And both screening and assessment is not in order to predict. We are very bad. I mean, there's many literature things that say we have about a 0 chance of correctly predicting who's going to kill themselves and who's going to not. But what you screen and assess is in order to manage and intervene. And so, as Jessica was talking about, Hennepin has started the SAFE-T as part of a more making sure they can get everybody on the same page of what to assess and how to figure out how to manage. In Allina, we've gone with the risk assessment and management protocols that come out of dialectical behavior therapy, which have been shown to stand alone, as well as the collaborative assessment and management of suicide. Again, if you look at these different tools, they all have similar principles in which you're assessing the things that are going to put you at risk to going towards suicide as a solution. And they also help you assess what is protective for you, what can help you, that even though you're this upset, will help you at least not act on suicide thoughts. And then the management is really important, because then it's how you engage with the patient and their loved ones to decrease the drivers of the suicide and the risks, the indirect indices that show you're at risk, like you're not sleeping at night. Not sleeping is a terrible indirect risk that we know that if we help you sleep at night is preventative. Being socially isolated, helping manage you by making sure we get you connected is crucial. Connection is crucial. And of course, evaluating whether they have lethal means, because reducing lethal means is one of the most straightforward things you can do to prevent suicide. So all of those are part of assessment and management principles that occur in any of the evidence-based approaches we use in the emergency department. There's a nice one that I don't know, I think they changed the name. Joan Arneston and her team have done randomized controlled trials on for the family intervention for suicide prevention in the EDs. Again, as you go down into the youth ages, it has the same things within it that the CAMS, the LRAMP, the safety have, but it purposely guides the clinician in how you engage the parents and the child in preventing suicide and helping set them up for success. And then we'll talk a little bit later about the good news is that what we know how to do to prevent suicide and actually getting people to do it has been the rub. And the expertise in how to assess and manage, when people are actually in emergency departments assessing people, it can be stressful for the assessor and the person managing, because they themselves worry about, what am I going to forget? Am I going to get everything? So bringing computer assisted devices into the assessor, to the crisis clinician, actually brings the expert, in a sense, standing right by them as they're seeing the patient. And it's those kind of things that can help improve our ability to assess in a more adherent way to the principles that work. Next slide. So then in terms of determining disposition, we'll talk a little bit about this, both myself and Jessica, about disposition options. Again, disposition depends on how you manage. If in your management, you are able to help the person solve the problems that are driving them to suicide, reduce the stressors in their environment that make them vulnerable to that, increase their connection to caregivers, loved ones, and to next day appointments, all of those put together really allow you to move into dispositions that are the least restrictive. The other point here about in the emergency department is observing. Of course, those who know me know I get on my my soapbox about the word observation. We're never just observing someone in the ED, we're doing clinical interventions. And so if someone, a tincture of time in the emergency department can be very helpful, but they're not just sitting there. What we're doing during that time is problem solving with them and their family, is trying to teach them new behaviors to tolerate their distress, and also troubleshooting the discharge for what would go wrong if we are able to get you to least restrictive. So that does take time. A number of you are familiar with the empath model, emergency psychiatry, assessment, treatment, and healing units. These have been set up around the country. Minnesota is starting to do that. We all know Fairview has that set up. Centricare, shout out to them. The St. Cloud unit went live about 3 or 4 weeks ago, after they waited for the foam for their chairs, because we all have supply chain issues these days. I don't know if I'm allowed to say this. If Larry Hook is on there, he can tell me to be quiet. But in any case, the nice thing about an empath unit as a place in which you do assessment and management of suicides, it does allow you to bring in people from the community, the family members, and really work with the patient at a comprehensive disposition that helps them go in a direction of being able to not continue with suicide as their solution. So why don't you go to the next slide then? So I'm just going to talk briefly about this. People are often, particularly emergency room physicians, are always quick to want to know the black and white, hospitalized or not hospitalized someone who's suicidal. And there are principles to this. You know, the first sort of statement I would say is hospitalization should not be your go-to, your automatic if someone is suicidal or has had a suicide attempt. That is not the first thing you think of. The first thing you think of is assessing them compassionately, helping them manage, and then depending on the outcome of that management, making decisions of the disposition beyond the emergency department. In hospitalization, we really look at what the benefits of hospitalization are versus the risks of hospitalizing. Hospitalization can have risks as well as the benefits and risks of less restrictive settings. Hospitalizations in the immediate moment can watch people so they don't kill themselves while they're on the hospital unit. But we don't have a lot of evidence about what hospitalization does over the long-term trajectory of people who are suicidal. We have more evidence about interventions that are like the CAMS, like the Risk Assessment Management Protocol and DBT, that do prevent suicide in the long run, separate from whether a person's in a hospital or not. And we do know that when people leave hospitals, it is a well-known fact that those 30 to 90 days after leaving a hospital is when people are at the highest risk for a suicide attempt. So again, you don't want to think of hospital as, oh, good, they're safe. You want to think about really what are we sending them into the hospital for? Is the patient highly psychotic and really becoming unglued, and they don't have the support in their home or their community to help them shore that up while they're recovering? You know, is the depression so bad that they're almost catatonic or they have a psychotic depression? Those are going to be the reasons. Sometimes you have people who are bipolar, their medications really need to be looked at. They're in a mixed state, you know, so you want to think about hospitalization about not just what it'll do for them from a suicide perspective, but for also the underlying mental health that may be associated with it. On the other hand, these protocols and processes that Jessica and I have talked about are evidence-based for suicide as a phenomena transdiagnostically. So I'll stop there and we'll go from there. Oh yeah, get rid of lethal means, please.
Absolutely, and really that concept of removing lethal means is part of safety planning. So next recommendation is to make sure that you partner with the person that is presenting with suicidal ideation to create that safety plan. Safety planning is an evidence-based intervention in itself. It allows the clinician to really foster that connection with the patient, and to Suzanne's earlier points about engagement, helps to generate hope, and it's really doing something useful in the moment. And really going through the elements of a safety plan, for example, the Stanley Brown safety plan template, which is the most well-known and evidence-based form of the safety planning intervention. You know, it's really, it allows that person to kind of really visualize what it looks like when they're starting to enter into a crisis, and also really understand the tools that they have at their disposal to address that crisis. You know, it really addresses, you know, what are the person's personal triggers, warning signs, what coping skills do they have on their side, what helpful people do they have in their life that they can call when things start to get bad for them, and then, you know, what to do in an emergency situation when that suicidal ideation starts moving toward intent. And again, part of that too is looking at, you know, what lethal means do you have available to you, and how can we partner with your family, friends, or others to make sure that those are removed or that access to them is difficult. And so it's a helpful intervention in itself, and it also gives the person a tool that they walk out of the door with, right in their hand. They can put it in their pocket or their wallet and pull it out at any time. And there's more in the recommendations document about safety planning. And then finally, we'll talk about post-discharge follow-up. This is both kind of that formal referral piece to ongoing care, which is usually necessary for folks experiencing a high degree of suicidal ideation. But it's also about kind of those informal contacts that we can provide to the patient to show that we care and check in with them. And even an auto-generated postcard from your electronic healthcare record system could be a benefit to that patient. Studies have showed that's actually a very effective intervention and can help people feel cared for and have that hope.
We have.
I'm sorry, Connie, go ahead.
Yeah, before we move further, we do have one question here. And so thank you for the question. It is, how can we help doctors understand that admission is not always best and have less fear about liability?
I'll hand that one to Suzanne.
Yeah, I think, Jessica, thank you. It's hard to teach everyone every little detail about this. What I find, because I work with all the emergency medical directors at Allina, is I've had the fortune of really being able to start showing them and educating them about the use of evidence-based tools for assessment and management. And what I have observed, because we have hundreds of emergency physicians at Allina, is that their trust with our ability to be using evidence-based tools that also help us with looking at pros and cons of hospitalization, pros and cons of going home, they've become much, much, much more trusting. So I think that part of this is, I would have to say that if you're not doing this kind of actually treating the suicidal crisis, I mean, we treat crises when they come in the ED. If you have chest pain, we assess it and treat it. And not every chest pain goes into the hospital. If we put everybody with chest pain in the hospital, we would all be talking about the cardiology bed shortage in Minnesota. We assess it in order to know what intervention to do. So as emergency room physicians are working closely with these tools and crisis clinicians and other ways of assessing and intervening effectively with patients, at least my experience has been that they really do understand more and more what we're trying to do in order to really help the person in the long run, not just simply lock them up. That being said, I also am really careful to listen to an emergency, I do emergency psychiatry, so I work with the emergency specialists, is to listen carefully to what their fears are and help explain to them what I'm doing or not doing with the patient. So it's a couple-tiered effort. I think it starts with anything you can do to implement evidence-based assessment and intervention for suicidal people in your ED. That will come along to the attending, because the attending needs that help with that as well.
Thank you, Suzanne. There's another question here. When risk is assessed, do you look at acuity of risk separately from chronicity of risk to determine the appropriate intervention?
Jessica? And I'm happy to take it as well.
I'm going to let you take that one as well, Suzanne.
Yeah, so this is really interesting. I've been working with highly suicidal people as my major population for 30 years now. And as we get better in the EDs with this, I can finally retire. So chronicity of risk does not mean that you are free of a risk of suicide, because people who are chronically and repeatedly suicidal have the highest rate of suicide. So that is part of what you assess, is what was the immediate driver. So there's people who sometimes at a baseline, until they get really good treatment, can wake up every day feeling like maybe it'd be better if I was dead. And so part of your assessment is, what is the change in that baseline, number one? What are the immediate precipitants that led to this going to the highly more urgent level? And then again, the management is solving that precipitant, increasing skills and other things you could use. Who do we connect to? So it's really again, it's not a numbers game. It's really how you assess with the patient of what could be managed. But you certainly don't want to be dismissive of someone with chronic suicide or non-suicidal self-injuries at just how, just that, in other words, you don't want to dismiss that, oh, they always say this, they're not going to kill themselves. That kind of language has got to go. You know, things like suicide gestures, that's got to go. I mean, really, if someone's mode of solving their emotional distress is to be dead, then you want to join with them on what can they do instead of being dead, and at the same time tell them, no, don't kill yourself. I have no proof that if you kill yourself, you're actually going to feel better. So what can we do to actually help you get feeling better? So it really is part of the sophistication of the management. Jessica, do you want to add anything? Because I know that comes up on your end as well.
No, I don't. I really defer to your expertise in that area. I feel like I'm more of the workflow wonk here. So I think that was elegantly addressed. Thank you.
Thank you, Jessica. And thank you for being a workflow wonk. Oh my God, we need that as well.
This is great discussion. So one other question came in, and I will comment to that, and that is a question about what does the evidence show about sending letters and postcards of support? Is there evidence to support that? Yes, there is. That is in the evidence summary for these recommendations. So we'll send it out to participants on the webinar, and you can find it on ICSI.org as well. Suzanne, Jessica, if you want to speak more to that, I know this has been a big topic of conversation and things where people have been working for a long time to try to get to that further part of post-discharge follow-up.
You know, just in speaking to the evidence of it, you know, collecting, learning what it is through research and randomized controlled trials and what actually prevents, if you do X, the person won't kill themselves or are less likely to kill themselves. It is supremely difficult to do randomized controlled trials in which you take one group and say, we're going to do nothing when you're suicidal, or we're going to do this, the control, which we don't do anymore. We do things like CAMS and LRAMP, and you get assigned to one or the other because you want to see if CAMS is as good as LRAMP, for example. But one of the things we know better than any is the research that's been going on since the 70s on caring contacts. And it is these non-demand letters. It has probably the most robust evidence that it does prevent suicide, is getting these intermittent non-demand letters saying, thinking about you from the ED. So yes, anything you can do with that. We can discuss more about where organizations are going with that as well at the end.
All right. Well, thanks everybody for the wonderful questions. I'm just going to review kind of where we've been in the past couple of years at Hennepin Healthcare with the kind of redevelopment of our suicide prevention workflows, really prompted by the release of National Patient Safety Goal 15 by the Joint Commission in 2019. And admittedly, we were a little bit behind the curve in really getting our workflow standardized around the CSSRS and the safety protocol. Of course, we had processes in place prior to setting out on this journey, but different areas were doing things in vastly different ways, and not everybody was using that validated screening tool, or for that matter, the evidence-based assessment process in areas outside of our psychiatric services areas. So in August of 2020, we went live with universal screening using the CSSRS upon arrival to the emergency department, as well as upon admission to the inpatient units if the patient meets certain criteria. We standardized the use of that safety protocol for our assessment process. And then established workflow for the management pieces, including making sure that patients are safe within the inpatient setting, as well as what is the protocol for rescreening and reassessment, and safety planning, of course, that really important piece of safety planning. We have continuously been looking at these workflows over the past, over a year now, and making improvements to those workflows to meet the needs of our clinicians and of course our team members, making sure that they have the tools that they need to be caring for these patients. And it's been quite the journey. I would say we've had probably 4 large updates to our inpatient workflow since last year. So we continuously are auditing it, getting feedback from leaders and our frontline staff about how we can improve. And then just this past June, we went live with universal CSSRS screening in our outpatient psychiatry clinics and treatment areas. So day treatment, partial hospital, et cetera, where patients are being screened with the CSSRS at intake. And then they're getting that since last contact version at time of treatment plan update or at each visit, depending on the clinic setting and the frequency by which patients are seen in those settings. And then we do a safety assessment for all patients at the time of intake, along with the CSSRS. Thinking the CSSRS just gives us that extra information if the patient is actually going to answer those questions, but we're still going to assess everybody who's presenting for care at that intake visit. And then at subsequent visits, they're going to be screened with the CSSRS, and if they show up moderate or high, then they're going to get a safety assessment again and take action appropriately. And up next, we're looking at our Equiparati clinic. It's a specialized clinic here at Hennepin Healthcare that serves Spanish-speaking adolescents. The leader of that clinic has been engaged in our Zero Suicide Learning Collaborative and really kind of is pulling on us to get those workflows implemented in that clinic. So that's kind of our first step into the non-mental health ambulatory world in our system, but we're excited to see what that yields. And you can flip to the next, Tani, please.
Sure. We do have one question.
Sure.
I'm curious if you've seen any fatigue from patients with the continual use of the CSSRS being used so frequently.
Really good question. I have not heard that, through our conversations with our frontline staff who are actually doing this screening. I've heard some complaints from clinicians, especially in the ambulatory setting, that they, it's something extra in their workflow. But that is something that we'll continue to pay attention to, as our workflows kind of mature on the outpatient side. And we're kind of rethinking how we look at patient experience here at Hennepin right now. So hopefully we'll have some opportunities to really bring questions like that to our patient council that's kind of being reformed right now, so we can get an answer to that question. But nothing that I've heard as of yet. Thank you for the question. So just some successes we've realized. Again, we're moving closer to universal screening for all patients. Our inpatient workflows are stabilizing. We have not had any sentinel events related to suicide attempts in the inpatient setting since these workflows were launched. We've really started to look at that equity piece. We do have a wonderful health equity team here at Hennepin that is a resource for us. But we really want to go further with that and understand, what our outcomes look like across populations. And also, are we using the right tools for every individual? The CSSRS does have some linguistically validated translations that we've tried to get into the hands of our interpreters. We need to do a little bit more work there, but we've had those conversations. I also had the pleasure of presenting at the EPIC EHR users group meeting just this past late August, so just about a month ago in Madison there, and kind of shared our journey there. So that was a really nice opportunity to share as well. And Joint Commission visited us in late July, and we had no findings related to NPSG 15. So we feel really great about that. We did get feedback from our surveyor that our policy was well written and easy to understand. So that's wonderful. And then to come, we're still not up on caring contacts very well, and it's really kind of our next big push, I think, with regard to that management piece. So we'll be delving into that and some other things here. But I'll hand it over to Suzanne and let her speak to Alina's journey.
Great. And before we do, we have some more questions, which is wonderful. We love this discussion. So one question, I think this is, it's asked as Jessica, as you're presenting, but I think Suzanne, if you have a different answer, please chime in as well. And that is, who completes your safety assessments?
So the safety assessment is conducted by, let's see, it depends on the setting, but usually it's either a mental health professional, psychologist, psychiatrist in the outpatient setting. On the inpatient setting, really, and I forget, we're talking about emergency department, so sorry, I'm like all over the place here. We do have a psych consult service that does help out on the inpatient side for our med-surg units. But in the emergency department, it really depends on that screening. And if a patient screens moderate or high, we may send them over to the psychiatric area of our emergency department, which is acute psychiatric services here at Hennepin. If somebody's kind of in that moderate risk level, we have given the tools to all of our emergency department clinicians, so MDs and APPs. So if they're planning to dispo somebody from the emergency department and there's no other, they're not in the high risk category, there's no concerning presentation there doesn't seem to be a decompensation of mental illness, those emergency clinicians can complete that safety assessment and dispo the patient.
Thank you. And then another question, and this is a great discussion point, is there a role for peer support specialists or those with lived experience as part of the healthcare team in the ED? And is this more relevant with some cultural groups than others to promote trust and collaboration?
I think absolutely yes. And unfortunately, we haven't really had the resources to bring that role on in our emergency department per se. Of course, have had fantastic success, for example, in our crisis residential setting, with utilizing peer support specialists as clinicians. I think that's a no-brainer for sure, but I'll hand it over to Suzanne for more.
Amen. Yes. And we're still, I have, Alina's got to line it up so we can do that. I mean, this is the issue. It's interesting to me with people with lived experiences are crucial in helping suicidal people who are the same culture as you, who've been through these things, are actually crucial for this. And it's interesting because when you actually look at, for people who are suicidal, where do they go? And they don't come to the ED or mental health. That's their third choice. Their first choice is friends and family, and their second choice is spiritual advisors. So the fact that they're in our ED is almost an anomaly. The vast majority of people who are suicidal or have suicidal thoughts aren't even coming to us. So if we can bring the same people that would be naturally who they're more comfortable with into the ED, and I'll talk a little bit more about the people with lived experiences when I talk about where we're heading in Alina as well. Great, yes, please bring on peer support specialists. Amen.
Okay, good. And just a comment from another of our participants that what a great way to increase engagement with our marginalized populations.
Oh, yeah. Sorry, I can't, you could see there's a number of things we could go off on a whole workshop on. Absolutely. So I don't have as nice a slide as Jessica because I'm not the flow wonk. And so Toddy did this for me, so I'll just try to describe it. So again, I'm going to just focus on Alina's emergency departments. There's things going on in our primary care clinics, our psychiatric specialty clinics, inpatient, et cetera. But from the point of view of the emergency department, we actually started universal screening using the Columbia in the EDs. So anybody who came in who were, I think we started with, I think we actually do it for 10 and up, not 12 and up, but you know, 10 to 12 and up, was using the Columbia screen as part of their triage in the ED, not just people coming in for mental health. And then subsequent to that, we were at the same time educating all of our mental health crisis clinicians. We have 24/7 mental health crisis clinicians. They're licensed mental health clinicians. Most of them are LICSWs, but other master level licenses. And so we have them 24/7 in the EDs. So by 2019, we were training them in the assessment and management protocols for really getting down into the weeds with someone, how to help them. Again, this whole issue of indirect indices or, you know, concerning presentations. So they'd started that in 2019. We also then added to that safety planning intervention, which you may see as crisis stabilization planning, as well as the future evolves is kind of how people are talking about it. And as Jessica said, safety planning isn't a safety plan, it's a safety planning intervention that depends on good assessment and management. If you talk to Dr. Stanley, she and I talked about it before we implemented it in Allina, was it depends on that you already have an assessment and management protocol going on, like the safety. So then we were fully implementing safety planning intervention by February of 2020, and then a little pandemic happened. But it's going on from that, what we're moving to right now is bringing the expert into the ED with computer assisted training. There's a tool that I can talk about in the next slide, but in a second. So we're actually bringing in the tool for computer assisted assessment management, crisis stabilization planning into the ED. We're in the process of that implementation process right now. It's quite a big lift. And so the good news about that is I don't have to run around continuing to train our emergency psychiatrists and our mental health crisis clinicians and how to do risk assessment and management, because it'll be just in time training as they do that with the patients. And then we have on our docket the caring context, like Jessica talked about. So that'll be a step after once we get the Jasper and other things rolling. So there you go. Oh, Jasper, yes. So it's this Jasper is, you can go to their website, is a computer assisted tool in the assessment and management of suicidal people. The nice thing about it is it going back to the peer thing, it brings people with lived experiences into the tool with patients, as well as it's a computer assisted assessment that's done more conversationally. I think the question someone asked about, are people fatiguing of the CSSRS or the safety? It can be somewhat robotic. In fact, the Columbia is actually developed to be a self-assessment. You don't even have to ask them. If you give it to them and let them fill it out, much like we do PHQ-9s, you're actually more likely to get honesty than feeling like someone's just reading me a bunch of questions. But anyway, so the Jasper will bring in the people with the persons with lived experience, the deep assessment, the stabilization planning, and the decision-making guidelines for the emergency department clinicians as well about disposition. So we're really excited about being able to implement that. And I think we're almost out of time, so I'm going to let Tani send us out.
Great. Thank you very much. Thank you all for being here. Here's just some statistics about, again, the need is great, and we need to equip both our ED staff and, importantly, our people who show up for care in the best way possible and meet their needs. And final quote by one of the people that we interviewed previously. So Suzanne Witterholt, Jessica Malone, thank you so much for taking the time to be here and share this work, your knowledge, and this journey. And thank you to all of you who've been here today to add your questions, and have a good day. We'll see you. Thank you.
Thank you. My pleasure.
Thank you.